Patrick has chronic obstructive pulmonary disease, also known as COPD. This includes two types of diseases, chronic bronchitis and emphysema. Smoking is the main cause for both of these diseases, and Patrick's history reveals that he's been smoking for roughly 40 years. It is likely that Patrick has some degree of both of these diseases. He presents clinical features of chronic bronchitis by regular coughing from accumulating mucus as a result of chronic inflammation of his bronchi due to him smoking. He also suffers from dyspnea, difficulty breathing, which is a clinical feature of emphysema. Smoking causes the alveoli to collapse, losing its retraction and elasticity, leading to increased residual volume and poor deflation. Excessive use of compensatory accessory muscles cause fatigue as they work harder to compensate for the lungs' dysfunction and try to increase oxygen. Patrick presents fatigue and also has other risk factors towards COPD, such as his age of 78, as this disease is more likely to progress in the older population. Patrick is suffering from tachycardia, which is an increased heart rate represented through a rate of 115 beats per minute, when a healthy rate is between 60 and 100 beats per minute. This may vary for hypertensive patients. Patrick's height of 180 centimeters and weight of 95 kilograms give him a BMI of 29.3, which is considered borderline obese. Patrick's excess weight increases his heart rate due to an increase in cell size, hyperplasia, and the number of cells, hypertrophy. These cells require more oxygen, thereby increasing his heart rate. Another contributor is Patrick's likeliness of central obesity, indicated by his increased waist circumference being above 94 centimeters at 140 centimeters. This can increase heart rate as the fat cells stored around his omentum are metabolically active, thus requiring more blood flow to be directed there. Abdominal fat also has a higher response to sympathetic activity of adrenaline, which can increase heart rate as adrenaline causes vasoconstriction as part of the flight or fight response. Furthermore, as a result of a myocardial infarction, or MI, adrenaline and noradrenaline are released. Patrick had an MI to the left side of his heart, permanently damaging cells due to insufficient blood supply known as ischemia. Prolonged ischemia causes necrosis, and since cardiac muscles are unable to regenerate, the remaining heart muscles have to compensate for this damage. In Patrick's case, the right side of his heart would experience hypertrophy and work harder to sufficiently pump blood around his body, thus increasing his heart rate. Left-sided heart failure would have developed independently from COPD, but is likely a result of having a MI to a branch of his left coronary artery, along with some other factors. An MI damages heart cells and causes necrosis usually after 20 minutes due to prolonged ischemia, where an insufficient blood supply doesn't reach downstream due to the blockage and heart cells can't sustain aerobic respiration any longer. This is shown in the bottom right picture where a section of the heart has died. A cause for an MI is atherosclerosis, causing coronary artery disease. Atherosclerosis is where fat accumulates on the wall of an artery. Major risk factors for this are the buildup of fat, which could come from Patrick's low levels of high-density lipoprotein, or HDL, and high levels of low-density lipoprotein, or LDL, as well as his high levels of triglycerides. Other risk factors Patrick has include increasing age, male gender, and cigarette smoking. He could also be at risk of hypertension, with a blood pressure of 135/85 millimeters of mercury, which are nearing parameters of 140/90 for defining hypertension. His blood pressure currently could be seen as low if he is already hypertensive. Hypertension is a significant cause for left-sided heart failure and can worsen it, as it increases the resistance of blood ejecting from the heart. When blood is ejecting out of the heart, it's met by the backwards pressure of blood. If there is increased resistance, there is a lower stroke volume, worsening the forwards effect of left-sided heart failure. Further risk factors for Patrick's hypertension include him being overweight, his history of smoking, gender, and indications of hyperglycemia from his blood test results. Hypertension also has clinical manifestations that can cause an MI, atherosclerosis, and left ventricular hypertrophy. While COPD can cause heart failure, It is unlikely in Patrick's case, as COPD often causes right-sided heart failure. Chronic bronchitis causes inflammation to the epithelial cells lining the walls of the alveoli, which enlarges submucosal glands, which then produce excessive mucus that decreases the diameter of bronchioles, thus trapping air in the alveoli. When inhaling, air is able to push past the mucus. However, when exhaling, air is trapped due to the mucus plug, which leads to hypoxia, hypercapnia, and increased residual air. This can cause pulmonary edema, which will later be expanded on in this presentation. Emphysema doesn't cause heart failure, but causes hypercapnia and hypoxia, since the elasticity of the alveoli is lost, thus causing increased residual air as carbon dioxide can't be exhaled. Right-sided heart failure, which Patrick has no history of, can cause left-sided heart failure. Therefore, it is more likely that Patrick's left-sided heart failure exists due to the factors mentioned previously, and COPD just worsens the effects of the existing heart failure. Patrick is at risk of developing right-sided heart failure, as both COPD and left-sided heart failure can lead to right-sided heart failure. COPD can cause right-sided heart failure as blood is pumped from the systemic circulation, with venous blood returning to the right side of the heart to be pumped to the lungs. Carbon dioxide picked up from the body can be exhaled, and oxygen from the pulmonary circulation can be picked up at the lungs to return to the heart, so the oxygen-rich hemoglobin can be pumped around the body. However, if there are deficits in pulmonary circulation due to COPD, it affects gas exchange, leading to pulmonary edema. It also causes pulmonary hypertension, as there is increased pressure from impaired gas exchange and the accumulation of fluid. This leads to fluid retention with increased preload, affecting stroke volume. Patrick's left-sided heart failure can also lead to right-sided heart failure. This is because of the backwards effect of pulmonary edema, as there is an increase in preload and afterload. Thus, the blood cannot be sufficiently pumped out, so it goes backwards, entering the pulmonary circulation and pooling there. Fluid is then lost into the interstitial space from the high pressure, as blood cannot be ejected from the left ventricle properly. The forward effect of the left-sided heart failure is the activation of the renin-angiotensin-aldosterone system, abbreviated as RAS, as not enough blood has been ejected from the left ventricle, so the kidneys detect a low blood volume and activate RAS to increase this volume despite there being enough blood already. Consequently, this leads to high blood pressure entering the right side of the heart, which cannot be ejected properly due to pulmonary edema. Blood is now lost to the systemic circulation, causing peripheral edema. Patrick is already suffering from some peripheral edema, as his legs are swollen below the knees due to venous return, unable to properly enter pulmonary circulation as a cause of high preload pressure. Blood test results show high levels of LDL at 3.5 millimoles per litre when it should be below 2. Low levels of HDL were also presented at 0.8 millimoles per litre when it should be above 1. Furthermore, high levels of triglycerides at 4.2 millimoles per litre compared to healthy levels of below 2 were also observed. This result of dyslipidemia may be the result of a stroke, which can have major impacts on neurological function, with results of confusion post-stroke. Additionally, his 150 millimoles per litre of sodium being greater than a healthy range between 135 and 145 may impact brain alterations through disturbing the sodium-potassium pump. It may also cause the loss of the first response, especially in the elderly who already have a decreased response. Patrick's bordering levels of high potassium at 5.2 millimoles per litre, with a reference range between 3.5 to 5, may impact neuron and muscle function, as hyperkalemia affects the resting membrane potential of an action potential, which is what the brain uses for cell functioning and controlling the body. He also has high levels of glucose at 8.5 millimoles per litre, known as hyperglycemia, when it should be below 6.1 millimoles. This can cause blurred vision, nausea, and vomiting controlled by the emetic center located in the brainstem. Lastly, His hemoglobin levels being below the normal range of 130 grams per litre at 111 grams per litre puts him at risk of anemia, where insufficient blood and therefore oxygen is reaching the brain for efficient functioning. Patrick's blood pH levels would be outside of normal parameter, as it is likely he has hypercapnia and hypoxia as a result of COPD and the backwards effect of left-sided heart failure, pulmonary edema. Insufficient oxygen levels and high levels of carbon dioxide affect the pH balance of blood. Blood pH levels should remain between 7.35 to 7.45. Blood pH is lowered by hypercapnia, which can cause respiratory acidosis, where blood pH is less than 7.35. This would be expected in the case of Patrick.